Okay.
So this is, he has a compartment syndrome.
So he wanted to do a fasciotomy. But
Yes.
to fasciotomy, what the nerve, which compartment first? Do you think this one?
This one, I think it is anterior compartment.
Correct, because big toe, right? Dorsiflexion. So
Yes.
it's anterior compartment. So what nerve is what I'm going to ask you, I think, right? So let's see what's the
Okay. Superficial nerve. No, I don't think it is the one. Deep peroneal nerve. I think this is the right answer. Femoral nerve. No. Profunda femoral nerve. Also no. Medial posterior tibial nerve. So I think the answer is deep peroneal nerve.
Okay, I mean, femoral nerve it can be, and profunda is easy. So end with a 3. The posterior tibial nerve is where usually? Which compartment?
Posterior tibial, deep posterior.
Yeah, it's a deep posterior compartment, which is not here. So if they were talking about compartment, then you pick up this one. So end with the deep and superficial. Do you know what superficial peroneal nerve, which compartment? Is the lateral compartment. So anterior compartment is the deep, and lateral compartment is the superficial peroneal. For this one, it's anterior compartment, so usually go with the deep peroneal nerve. Okay, but I will tell you this one just in case, because sometimes they may change it. They give you maybe lateral compartment, they give you posterior compartment. You know, you never know. So you have to know which nerve. You know, and this is an important. You know, so just or go back to anatomy, guys. Read about these nerves. But in general, anterior compartment is the deep, lateral superficial, and posterior is the posterior tibial nerve. Okay. All right.
Okay.
So this is good. So let's go to the next question. Who's there? Yahya. I want to take this one, Yahya.
Hello, Dr. Samer. Okay. A 55 years old woman with insulin dependent diabetes present with a non-healing diabetic ulcer and neuropathy after she walked in her child toys. A few days earlier, her lab values are abnormal with fasting hemoglobin A1C 12. She has no palpable pulses in the pulses with a toe brachial index of 0.2. The component that define the pathophysiology triad of diabetic foot ulceration are?
Okay. So they're asking what the trial pathophysiology, the main 3 pathophysiology for diabetic foot ulcers. Do you know them before you go to answers? What the 3 things can cause diabetic, or what the 3 pathology lead to diabetic foot ulcers? It's 3 of them, 3 major pathology.
Neuropathy.
Neuropathy, correct. Second,
our
specialty, vascular, right?
Yeah. Third one, infection.
An infection, right? So the 3 things can cause diabetic foot ulcer, the 3 of them. Combination or each one itself, but usually 3 combined, they lead to diabetic foot ulcers: neuropathy, vascular disease, and infection. Okay.
Yes.
This is the main triad for pathophysiology of diabetic foot. So now you go through the questions. See what. Let's start one by one. With the first one.
Neuropathy, arterial occlusive disease, and trauma with secondary infection. This is the right answer. So, B, hyperglycemia, hyperlipidemia, and repetitive trauma. C, neuropathy, muscle atrophy, and bone deformity. D, hyperglycemia, arterial occlusive disease, and skin barrier deterioration. E, neuropathy, glucose level that are difficult to control, and muscle deformity.
So if you look at them, I mean, yes, all of them are involved, but they're not the classic trial. You know, if they tell you what the pathophysiology, yes, all of them is the pathophysiology. All can lead to ulcer, but that trial, diabetic foot ulcer, are very well known. Is, as I said, neuropathic, which can lead to the deformity, muscle deformity, you know, toes deformity, and lead to the paratrauma, to the skin, decreased sensation. So all within neuropathy. Then the vascular comes because of low perfusions, and then the secondary infection. So this is the 3 main pathology. The reason why when you treat diabetic foot, you have to target all of them. You have to treat neuropathy. So if you have any deformity, you have to correct it, like Charcot joint offloading. You have to fix the vascular disease and you have to treat the infection. If you just take one of them only, what we do us, that's why we are not very successful when we treat diabetic foot, because we main concentrate on arterial-occlusive disease. We are not very aggressive with infection. We're not good aggressive with a wound, with offloading, you know. So you have to really target 3 of them to get a good success result with diabetic foot. Any question? All right, it's not much really about this question. You just have to go through the pathology. All right, 33. Ahmad Dahman, you want to take it, Dahman?
Yes, doctor.
Okay.
42-year-old woman with a long-standing history of diabetes present to her primary care physician with a wound on the plantar aspect on her first metatarsal head, which has been present for several years. She cannot recall any antecedent trauma. Urgent referral for further evaluation should be promoted in the presence of.
Okay, so she has a long-standing ulcer.
Yes, difficult to heal.
For several weeks. So what
Yes.
things should alert you to send her as very urgently for evaluation? Let's see what scenarios they gave you. Let's start first one.
First, a serious drainage from the wound. No. History of prior wound in the contralateral foot. Also no. Lack of palpable pulse in the affected foot. Yes, because that indicates also ischemia with the infection. Unexplained hyperglycemia. This can also alert you for sepsis. Duration of the wound.
Okay,
So
let's go one by one. Serious change from the not a serious, always get serious. Maybe it's chronic, nothing need an urgent, correct?
Yes.
Prior wound in the contralateral foot doesn't make any difference, okay?
Yes.
Lack of pulse in the affected foot, that means it's a vascular.
Yes.
Right. But this is a chronic, it's an acute, right?
It's not an urgent, yes.
Urgent, yes, you have to know it's not an urgent.
Yes.
And hyperglycemia, what does that mean?
Indicates sepsis or feature of systemic signs. So I think this is the one.
The one, yeah. So if you get sugar was not controlled, now I explained, then that means she has a sepsis. Then yes, you have, because people diabetic sometimes they don't show you a sign of sepsis, like a fever, tachycardia, you know. You don't see typical sign of infections. So when you see unexplained hyperglycemia, should trigger your attention. So you may have dealing with a sepsis. So she needs really an urgent referral to the hospital, either for debridement or antibiotic or something like that. The duration of the wound doesn't make a difference. So make it confused between C and D. But remember, vascular is issue, but it's not an emergency. And as I said, urgent, you know. So the urgent if you have a sepsis, because they can go really bad with sepsis. So the urgent referral here if you feel a sepsis, and the sign of sepsis in diabetic is unexplained hyperglycemia. And we see it quite often. You know, there's a reason patient come to us and say, okay, I know I cannot control my sugar when he has a bad infection, you know.
Yes.
All right, very good. Any question? Okay, let's go next question. Who is Saeed? Let's Saeed with us. Saeed, you want to go Saeed to next question?
Yes, sure. Okay, 63 years old obese woman present with a foul-smelling ulcer on the dorsum of her left great toe with tracking erythema and general feelings of malaise. She is neuropathic from the ankle to the toes. Recent lab work shows her hemoglobin A1C is 11.2. She has a fever of 102 and heart rate of 110. The next step in her management is.
Okay, before we go next step, what does she have? You think this patient?
She's in sepsis.
She's sepsis, right? Tachycardia, fever, you know. So she's septic, and she has a foul-smelling ulcer dorsum of her left big toe. Correct.
Correct.
So if we are in the ER and you call me and said, Dr. Koussayer, I have a patient this way, and she has fever 102, she's tachycardic, what am I going to tell you? What do you think?
Yeah, so I'll go by the guidelines of sepsis. So source control and few steps. So IV lines, draw blood cultures, give standard antibiotics, and do source control.
Access control and admit her to the hospital and start on antibiotics.
Yeah. So take blood, give her fluids, take blood cultures,
Let's go
and
through.
started and broadened antibiotics and do source control.
Okay, let's go through them. Okay, go ahead, one by one.
So food cultures, oral antibiotics, and close clinical follow-up as an outpatient. Okay, admission, I don't think, no.
No, just stop.
No.
You think just do full culture, give antibiotic and send her home? They calling you from
No,
the
no. Sure, no.
and they said, okay, we're going to do full culture, give her antibiotic and send her home to see her in the clinic. Is acceptable?
No, no, she's in sepsis, actually, no.
No. Okay, now go B. We're going to go one by one.
Sure.
Go ahead.
Admission, IV antibiotics, and 3 views of X-rays of the right foot and food cultures. So I'll admit her, I'll give her antibiotics, probably, but I don't think that's the ideal answer.
Could be possible. Let's continue. So this is like 50-50. Go next one.
Immediate operative debridement with possible open amputation of the grade 2 or raise with culture. Yeah,
Okay.
that's source control. Angiography with possible revascularization, but maybe it's not the first step if she needs it. Right below-knee amputation, no. So I'll go with.
So the question was they ask you what they want to ask to, you know, the
So
reason
next step will be B.
intravenous antibiotic and 3-way of the right.
That's the initial next steps. Yeah. Yeah.
The next step in the measurement. But she is, look at, she's fever 102 and heart rate 110.
Full culture.
You see? I mean, X-ray to see if osteomyelitis, antibiotic, yes, admission, yes. But they want you to be an aggressive. So as they try to tell you, you have to be an aggressive with this kind of patient. They're already in septic, you know, because like imagine this patient, you call the ER, okay, admit under medicine because just need antibiotic and admission. You think be enough?
No, I will give her actual antibiotics, do fluids,
But
do an OR, and admit her.
Yeah, so the different treatment is to debride it, to get the source of the infection. You need to do an amputations, right? Sure. This is the definite treatment. Because from B, it looks, you're just going to admit, I give antibiotic, get an X-ray, and just watch. And she's already in septic. If she has mild infection, I understand, but she's septic, you know? Because if you take B, that means she's going to go under medicine. Why you need to go under surgery? You're just going to give antibiotic, admission. So you're going to tell them over the phone, okay, just give antibiotic, admit her under medicine. And next day, they can call you, and it happened to us all the time. Guys, we need somebody to control the sort of sepsis, right? How many times we get a call from ICU because patients, she's in septic and they see, guys, this infection coming from the toe, you have to control the source of infection. So the first thing, the most important part to treat the source of infection. Because if you give a ton of antibiotic and you still have source of infection, this will never heal. So the first thing, you take the source and then you give everything. Of course, I mean, in real life, as you said, you're going to admit her, give antibiotic, but she has to go to the OR as soon as possible because she's septic, you know, and to amputation or rate, depending what, you know, what you decide. But don't just admit her and give antibiotic and sit on that. So the question is a bit tricky, but I think what they want to be sure that you are aggressive with this kind of people, especially as diabetic people. All right? Any question or convinced or not yet?
Yeah, sure.
So the best way is just to you know, to the next step in management is to take it to the OR and do debridement. Even though B make sense if continue, if you damage B and C. But if you B, it means just give antibiotic and watch, this is wrong. But give antibiotic and then they cut the OR, it's reasonable. So again, it's tricky. But again, the idea from this one, you want to know that you are aggressive, you know, with the treatment. All right. For the next one. Maitham, you want to take Maitham?
Yes, Dr. Samer.
All right, let's see what that's.
Okay, so a 53-year-old obese woman is admitted with fever and right foot pain. She noticed a malodorous wound on her right foot over the last 2 days. On examination, she has a palpable femoral, popliteal, and pedal pulses. She has minimal sensation to light touch and monofilament bilaterally. And the right foot is swollen and red with a small draining ulceration under the first metatarsopharyngeal joint. The most appropriate initial radiographic study is.
Okay, before we go. So she's 53. She has a chronic. She has for 2 days wound.
Yeah.
She's got pulses. So there's no vascular issue here because they said she has a femoral beta pulses. They want to tell you don't go to the vascular studies. This is very simple. She has minimum sensation, matter she has a neuropathy. But look at the right foot. She's swollen, red, and small drainage ulcers. Okay, first metatarsal joint. So we have ulcer. Yeah, and she has bad smelling above the metatarsal joint.
And they are asking about the initial radiographic study. I will go with the X-ray initially.
Why we do X-ray now? Why you want to do an X-ray? For what?
To see if there is an osteomyelitis ongoing, acute one.
Or what else?
A gas gangrene.
Correct. Else? So gas gangrene, osteomyelitis, and third thing?
Charcot, maybe. Deformity. That's clinical, not radiological.
What is body? Remember, they have a neuropathy. Sometimes they step on the needles, they don't know.
Any foreign bodies.
Yeah. So when you do an X-ray, you look at 3 things: for gas gangrene, for foreign body, and for osteomyelitis. Okay.
Okay.
So on the X-ray, do you know what sign of osteomyelitis? What do you see on plain X-ray? What's the sign of osteomyelitis?
There will be like radiolucency around the bone, distracted bone.
Right. Cortical erosion.
Cortical erosions, yes.
Pathological fractures. Yeah, mainly pathological fracture, cortical erosions, and osteopenia. Okay, decrease, density of the bone. This is mainly a sign of osteo on the X-ray. All right, so let's say what? So the most right. So what next step you're going to do? Let's say one by one.
So plain radiographs of the foot. This is correct.
Okay.
Arterial Doppler testing. Patient has a palpable pulses, so no vascular issue in this patient.
Okay.
Diagnostic arteriogram. No need for that also.
Okay.
MRI of the foot could be considered, but not as initial step or radiographic study to look for any collection, deep collections.
Okay.
CT with contrast.
Not going to help.
No.
The pulses, like a CT angiogram, we don't need. So really, the most important is the X-ray and MRI. It's what we do, right? But always we start with the X-ray first. And X-ray, most of the time, as I said, you see sign of osteomyelitis will be enough. But sometimes you don't see sign of osteomyelitis, like, or the beginning of osteomyelitis, then you do an MRI. MRI is more specific. But 90% you can see the result on plain X-ray. If you still have any doubt, then we order MRI, okay? But it's not our initial study. All right, they are easy. Any question? No.
Thank you.
So let's go to Osama. Back to you, Osama. 36.
Okay. 35-year-old man was brought in by ambulance to the emergency room following isolated high-velocity gunshot wound to the right leg. He was hemodynamically stable but without distal pulses. CT angiogram demonstrates occlusion of the superficial femoral artery with the associated hematoma. On surgical exploration, the mid-superficial femoral artery is found to be completely transected with a 10 centimeter defect after the proximal and distal arterial edges were debrided. A concomitant small injury to the femoral vein was seen and controlled with simple suture repair. The best means of repairing the arterial injury is?
Okay, so you have a
yes
wound, okay, to the right leg.
Yes, and where there is a defect of 10 centimeter of the SFA, and also there is small injury in the femoral vein.
But femoral veins, they fix it already.
Yes.
Simple. So we don't have to worry about the femoral vein. So try to concentrate on the femoral artery, right? Superficial femoral artery, mid part, okay? So you have 10 centimeters. Okay.
Mm.
Can you put them together 10 centimeter?
No, I think
No.
it need autogenous repair or graft at least.
Right. So because it's 2 centimeter, you can do it, but 10 centimeter is too long.
Mm.
Okay. So you have to do a vein. Okay, let's go through this one. Let's go through one by one. And tell me what,
Placement.
Yeah.
Okay. Placement of endovascular shunt and return to the operating room in 24 hours for definitive repair. No, I don't think this is a right answer. Primary repair with end-to-end fashion, but I think the 10 centimeter is too long defect, so I don't think end-to-end could works. Interposition with BTFE. There is because it is trauma patient and they already did debridement and it's because it's infected area, so I don't think the graft would be a good idea to put in the infected area or area of trauma. The interposition graft with ipsilateral great saphenous vein. We'll see the last one. Interposition graft with contralateral great saphenous vein. I think E will be the right answer because the vein in the same leg is already affected in the femoral. Even if it's small repair, so we don't want to compromise the venous in the same leg. So I think E the right answer.
Okay. First, again, Osama, we're not here want to answer a question. We want to learn, okay? So we have to take by one and see why you're right, why is wrong, okay?
Okay.
First one, you say, why we don't put a shunt and come in 24 hours? When we do that?
I think if there is a small injury, less than 5 centimeter.
No. When you said, okay, I'm not going to do a repair, I'm going to just put a shunt, put patient heparin, and come back in 24 hours. Can you do that?
I'm not sure. No.
Patient is stable, right? If patient is unstable, patient is vasopressors, hypotensive, has multiple trauma, lung trauma, chest trauma, head trauma. Patient is like messed up, It's not the time to spend 15 minutes, an hour to do a bypass. Okay? This patient, if he's unstable, just get him off the table as possible because the ortho is waiting to do his job. The neurosurgeon want to open the abdomen and do, maybe splenectomy. Maybe the neuro has to open the head to do, evacuation of head trauma, So in this situation, not the time to go and do bypass, So have a patient with multiple trauma and stable. Yes, just put a shunt now, get the flow, and let them finish. Then you bring him later on when patient is more stable, and then you can do the bypass different treatment. Okay, but
yes.
it's fit here because patient is stable. See, so they have to know because again in the exam they may play with the scenario and give you unstable patient. Then this maybe be the right answer. Okay.
Yes.
Primary.
Well, how can we do a shunt?
It's just a shunt. It's very simple. Like when you use argal, I use argal shunt. I know guys what you do for carotid. We just put it side on both sides and put patient heparin.
But if we don't have Inhara shunt,
the problem sometimes you cannot because patient has multiple trauma, then become an issues, Then mostly you can put a shunt only like for until become more stable, like until the other people finish, like the ortho, but then you have to do the same time, not 24 hours. Because 24 hours if you have a shunt will be thrombosed. So you have to put patient heparin. And you cannot put patient heparin if it has multiple trauma and bleeding. So let's say if he's unstable and multiple trauma, then I just put a shunt until other surgeon finish, like take the spleen out, open, the head, whatever, evacuate the intracranial hematoma, and after they finish and become more stable patient, then maybe I'll do a repair.
okay.
But the idea is that putting a shunt temporary only if his patient unstable, or if patient like patient has femur fractures, you don't want to repair it where he's doing, because if you do a vein and then do a femur fracture, it may disturb your anastomosis. So if he has patient an arterial injury and femur fractures, and the ortho need to fix the femur fractures, then you can put a shunt until they finish, and then you do your anastomosis, because be a lot of pulling and pushing, with the femurs. So you put a shunt until the ortho finish, then you do your definite anastomosis surgery.
دكتور سامر معلش على المقاطعة مصطفى الفيدنج تيوب can be used as a shunt الانفنت feeding tube إذا ما في هذا مو one of the answer كمان. If you don't have a shunt or carotid or anything, you can use the infant feeding tube.
That's
You
correct.
flush it with heparin and that's it.
If it's
Dr. Samer, question. Should we heparinize the patients while on shunt or not?
yes, if you can, but the problem is patient muscle is a multiple trauma. So you may give like a small dose. You have to be, play by ear, depending how situations, But usually, if you want to keep it 24 hours, you need anticoagulant, otherwise it'll be thrombose. Keep it like for an hour or two is not a problem. Like until they fix an orthopedics, that you can say because most people they already lost a lot of blood. They have a massive blood transfusion, so they already have like a kind of DIC, so they're not clotting because it's low because they have massive blood transfusion, all the things. So you can do it. But if you decide to leave it for next day, then it has to be on heparin. So if you can't put patient on heparin because he has bleeding, then maybe you have to fix it right now, right away. So then you have to make your decision at the table.
Thanks, Dr. Samer.
Clear? Okay. All right. So primary repair and the end-to-end, and we said it's not a good option because big defend. Interposition graft with a BTFE, of course, we don't do it because of infections, But again, like you said, let's say that you don't have a vein, he has very crush injury, or you have to go very quick. Patient has multiple trauma. You want to do very quick. You don't have time to waste to get the vein. You can put BTFE graft. What's a big deal? And then later on, you can come take it out and put a vein. You see, guys, always try to be more practical. You have to evaluate the time of surgery. Your priority get patient off the table alive. It's not salvage the leg. The worst thing is to salvage the leg and the patient die on the table. So if you feel that everyone rush you, okay, we have to go, and then I'll prefer BTFE then because BTFE is very quick. Get BTFE, put anastomosis, and you're done. And then later on, whenever he's more stable, he survived, always you can go there and take it out and put a vein graft. What's the big deal, So also just keep it back in your mind as an alternative,
Okay, Dr. Samer, one question. A primary repair, we can do it if the injury is less than 5 centimeters, or what is the limit?
It depends where is the artery, if you can mobilize it or not. Like SFA, you can mobilize it very well, really. I think 3-4 centimeters is acceptable. But like if you are as a tibial, you cannot mobilize the artery. Femoral artery is hard to mobilize it, So it depends which area. But the most area is SFA, usually injured by gunshot wound. So if you 2-3 centimeters, you can. And you have to evaluate your situation at that time. Sometimes you have to cut some of collaterals to bring the artery down. But I think 3-4 centimeters, you can bring it and get it together. And sometimes you have to put a cast to keep because the leg flex, so you don't get tension and anastomosis if you decide to go with primary repair. Okay. Now the question. So everyone agree that if you have a long, you need to get saphenous vein. This is like the right answer. But should you go for ipsilateral or contralateral? When you have a trauma to the leg, it's always better to go contralateral saphenous vein. Not because of venous injury, as you mentioned. It's just because the vein muscle is being damaged, with especially when you have a gunshot wound, because gunshot wound create a heat around it for at least like 2-3 centimeters. So it may damage your saphenous vein. So always is better to go to the contralateral leg and get your clean saphenous vein. So always when you get saphenous vein position, go to the uninjured leg and take it from there. This is the rules. If both are injured, then you choose which one is the less injured. Or you go to the arm and you take the vein,
Okay.
Especially it's a short vein, so you can get from everywhere, from anywhere. Still you can get it from the leg. Like if it's in the thigh, you can go to the leg down below the knee and get the vein from there. But the rule, guys, for you as an exam, if like this question, they want you to know that always try to get the vein from the good leg, The reason why his answer will be E. Okay. So it's different between the questions, the exam, and real life. In the questions exam, you have to go with the guideline, which is makes sense. But in the OR, you have to make a decision on the time. It depends how is the injury, how bad the injury, where is the injuries, you know. As I said, I mean, if the injury in the femoral area and he has a good vein below the knee, why not? You can go and take it out from there, you know. So it depends. I mean, you have to make the decision. But for the exam, the rule is that always you go to contralateral leg.
دكتور سامر سؤال في هذه الحالة I choose end-to-end anastomosis both side ولا I ligate the artery and I make it like end to side because it happened to me twice and I did one time end-to-end, one time end to side. I think end to side works better.
Okay, end to side work better. Okay. Yes and no, because end to side you have no problem with the mismatch with the sides, you know, the vein and artery. Especially the artery, they go to spasm when you're doing, like, especially the injury, you already lost a lot of blood, you see the artery spasm, you know. So what usually I do a beveled fashion. So when I cut the vein, I don't cut transfer, I cut beveled. So I make it big, you know, and the same for the artery. So when I do end to end, will be a beveled cut in the both. So you get a nice, you know, like end to end, but it's really side to side anastomosis. The best way, if the artery too small, is to do the posterior wall is running and do anterior wall interrupted. Because if you do running all the time and the artery is small, you can get a bursting effect and you end with a stenosis or occlusions. So the best thing I noticed that if the artery is small, especially these young people, these people, you know, so artery usually is small. It's not like what we see with atherosclerotic disease, chronic occlusions, the artery is thick, you know, and large. No, this artery usually is small. So what usually I do posterior wall running and then do the anterior wall interrupted. It just gives me more, you know, relief that the anastomosis, no bursting effect on the anastomosis.
Okay.
But if you have mismatch between the artery and vein, yes, you can do that. You can just do end to side and ligate the artery. But if you come in the exam, it should be end to end anastomosis.
Okay, great. Thank
All
you
right.
so much.
No problems. Let's go to next question, which is 37. أحمد ممتن معنا.
Yes, Dr. Samer.
Been hiding.
Yeah, I've got this 75.
Was it here? Sorry. Go ahead. Yeah.
75-year-old diabetic man presents with a 2 centimeter right malperforance ulcer over the right first metatarsal head, which probes to the bone. Despite offloading and local wound care, the ulcer has not healed after 6 weeks. ABIs are non-compressible, but toe brachial index on the affected side is 0.1. Angiogram demonstrates occlusion of the below knee popliteal, posterior tibial, and anterior tibial vessels, with reconstitution of both dorsalis pedis, posterior tibial arteries of the foot. The best approach, if angiosome-directed therapy is desired, would be.
Okay. Before we start, Ahmed, what is malperforance?
Malperfusion, ischemic ulcer, I think.
I mean, maybe I saw it once. I don't know why they use this term. This is neurogenic ulcer.
Okay.
It's just, you know, it is, I think, Latin word for neurogenic. They call malperforance. So it's a neurogenic ulcer. Anyway, so neurogenic ulcer, and it has an arterial component, of course. Below the knee, everything is occluded, but you have posterior tibial and dorsalis pedis open. Because they didn't mention anything about above the knee, you have to presume that everything above the knee is normal, right? Because they didn't mention anything. It said only below the knee. So you have to presume that external common femoral profundus fay or open, and even popliteal above the knee is open. So the only thing you have below the knee, everything included. So you want to do a bypass. You have two options: and posterior tibial and dorsalis pedis. And the ulcer is where? First metatarsal head. Is it plantar or dorsal? Because malperforance, I mean neuropathic ulcer, that means on the plantar, correct?
Yes.
That means below. Okay, so that means below is the plantar aspect of the first metatarsal head. Okay, so which artery is responsible for that? Let's go one by one. Let's see what the options. Well, before we go, which artery is responsible for this part of the leg?
if arterial system in the plantar aspect medially, it should be posterior tibial, marginal branch.
Correct. If it's a dorsum, then the
Dorsalis pedis.
tibia. Correct. So this is make a difference. Okay. So let's go at first one by one. What he said.
Femoral endarterectomy and profundoplasty. We don't have data from the above knee.
Right. So this is wrong. Okay.
Femoral posterior tibial bypass.
Could be, but the problem, why femoral? I mean, you can go from popliteal because he said nothing above the knee. So I mean, leave it to the end. Leave it to the end. Let's see next.
Okay, angioplasty and stenting of the popliteal artery with angioplasty of the peroneal. Angioplasty of peroneal will not target the angiosome of intent.
Okay, and they say what's the best approach? Okay, how old is this guy?
Yeah. 75.
According to the best CLI trial, what's the best approach with this
The
patient?
approach is bypass vein.
Correct.
With a good vein.
With a good vein. So this is what according to the new trials. Okay. So what if you want best approach should be a bypass. Correct?
Yes.
Okay. I mean, real life is different. You may try angioplasty, try whatever, but in the exam they want you to be more like scientific. So according to scientific, now we know that if you have below knee disease, critical limb ischemia, and non-healing ulcer, the best, if you have a good vein, then you do a bypass. If not good vein, then endovascular. They didn't tell us anything about the vein here, but we'll see. Let's keep going. So next one.
Next is above knee popliteal dorsalis pedis bypass.
Okay.
If the dorsum of the toe, the big toe, this would be a very good option.
Okay. Next one.
E. Retrograde access of posterior tibial artery with angioplasty and stenting of the superficial femoral artery. We don't know anything about the SFA.
That doesn't make sense.
I wouldn't choose it.
For me, none of them is correct.
Yeah, honestly.
Above knee popliteal dorsalis. No, because dorsalis doesn't go unless if they mean the dorsum. But they said malperforance also. Malperforance in neuropathic. And neuropathic has to be on the
plantar aspect.
Right metatarsal head, which probe to the bone. Alan, any suggestion? But I don't think I will do. I mean, if I do a bypass, I will do above the posterior tibia. If this ulcer, I understood for something up, then because posterior tibial dorsum is a posterior tibial, it's not dorsalis pedis.
Yeah, and then with the dorsalis pedis, you're gonna have problem with wound closure also. So with these cases, so in these patients.
You've been with us for a long time. Sorry, I just saw your name now.
No, it's okay. I just with the dorsalis pedis bypass, you always have to think about, is that wound gonna close or not? So this patient already it may not close the wound, and I think I would do posterior tibial bypass for that one.
Yeah. So again, some of the question really. So I'll do posterior tibial. Yes, I'll do above knee to posterior tibial bypass.
Yeah.
Retrograde access, all this one in real life you can try them, but it's not the best as exam question, not the best approach. Okay. If the posterior tibial is not available, then you can go to the dorsal pedis artery. You don't have to go directly to the angiosome. You can go to the other zone if you don't have the artery going to the angiosome you need it. It doesn't mean you should not offer the patient bypass. You can still do bypass to the other zone and depend on the collateral or the arch, the plantar arch, if it's intact or not. And most people now, they believe that the plantar arch integrity is the main things more than really the zone angiosome. Because if you have an intact arch, even if you go to any area, any artery, you get blood flow to the zone. So what do you think, Muhammad, about the angiosome? Are you one of big believer on it or not?
Well, I mean, I don't know. It's I don't believe personally in them very well, but now if you look at the work that Mustafa did, and he has a pretty good outcome with healing, but they don't stay open. When you do footwork, so I think the main thing, if like you said, if the arch is intact or not, and the outflow in the foot, and if you do bypass anywhere, it'd be okay, with the wound.
That's true. So I think angiosome, it makes sense, but you don't have to die for it, as you said. I mean, like, if the patient has posterior tibial and dorsalis pedis, but dorsalis pedis is a better artery, but posterior tibial is disease, and we have an ulcer in the plantar aspect, and I have a good arch, I may go to the posterior. I go to the good artery better than go to the angiosome. I pick up the good artery. It's more important than the angiosome. Agree, Muhammad?
Yeah, the only thing about dorsalis pedis in the diabetic patient with this type of ulcer, they may not heal. You know, that's I've seen this before where you do a nice bypass, but then they have wound issues with these patients. You know, and so with neuropathy, you know, you have to be careful. You know, of these patients.
That's true. Have you heard about this term malperforance ulcer?
Malperforance is an ulcer that usually associated with the diabetic neuropathy. Like you said, it's a neurogenic ulcer. Sometimes associated with ischemia, sometimes not. You know, so but this in this case associated with ischemia, but I think it's just usually it's in a diabetic patient.
That's true. Yeah.
Yeah.
All right.
So,
Question.
السلام عليكم دكتور سامر. Hello, Dr. Samer. May I ask a question, please?
Last question, yeah. Go ahead. You have a question? Hello? We cannot hear you.
Dr. Samer, can you hear me now? I'm sorry.
Yeah.
As the techniques for distal bypass, would you go for a DSA prior to go to choose your vessel? And if you are pushed to go for dorsalis pedis, would you go for a counter incision to close the skin over the bypass? And final question, would you go for post bypass completion angiogram or not?
Okay, let me be sure I got your question right. The first question, should I do DSA before the bypass?
Prior to the bypass, yes.
Right. I'll give you my opinion, and then we hear Dr. Muhammad, his opinion. No, the CTA is very bad for tibial arteries, you know. So really, if you want to do a target, you do a distal bypass, I will do an angiogram. Because CTA is very bad. You cannot see the tibial very well. So if I decide to go with a distal bypass, I will do an angiogram to see where's the quality of the artery, where's the best segment, and how is the artery. So I get a better imaging and better evaluations with the angiograms and CTA. CTA for tibial is, if you do FEMPOP above the knee, I understand. But if you decide to go really distal, then I think you need CT angiogram. This is the first one. Second one,
the DSA, would you go for selective angiogram through popliteal at the level of popliteal by burn or long sheath?
Yes.
Or would you go from femoral?
I mean, it depends, you know. I mean, how's your is a SFA disease or not? But usually, you need to put your catheter all the way down with current catheters all the way to popliteal and inject. You get a really nice selective angiogram, and you look and see. So this is well. Before I go to the next question, let's see what Muhammad said. Muhammad, what do you think?
I agree. So I agree with you 100% because everybody who has tissue loss or ulcer needs an angiogram because CT scan would not show good for tibial. If you on the fence and you wanted to get a test, the best test for tibial vessels is MRA. It's not as good as for other, you know, big vessels, like especially carotid or big vessels. But for tibial vessels, MRA of the tibial vessels, it shows pretty good. But everybody who has tissue loss has to have an angiogram. And I think that's very important.
Yeah, also the arch and to see everything and the angiosome area. So really need an angiogram, you know. The second question he asked, do you need to do a flap so to prevent dehiscence, if dehiscence at least away from it?
Counter incision or flap, what's your preference and how you do it?
I don't think, maybe I do a small flap, but not like very, because if you do a long flap, you may get a necrosis and you already have ischemic leg. So I may not put it, and the posterior tibia is not an issue. The posterior artery is deep and peroneal. The worst one is dorsalis pedis, what Muhammad said, dorsalis pedis artery, because it's very superficial. So of course I will not put it above exactly the anastomose. I'll do a flap, but also it's not big flap because you may end with a skin necrosis. So I may do, but it will be a very small flap, but I'm sure we'll not put it exactly above the artery. What do you think, Muhammad?
Yeah, I think coverage, coverage with the little muscle is okay, but like you said, you do a big extensive flap, you're gonna have ischemic. You already, you have necrosis and have ischemia. So
Yeah.
I think really the DP bypasses and PT and plantar bypasses, I mean, you read in the literature, they work, but also you have to, before you do them, you have to think about wound healing in these patients, because you may do a nice bypass, but they never heal their wound, and that's important. So
I had a patient who did a posterior tibial bypass femoral, and he got some skin issue necrosis. We were debriding him and carefully, and for some reason he went to other doctors who did. Maybe he didn't know that he has a bypass down. He did an aggressive debridement on him, and next day when he's sleeping, he has a massive bleeding. He died. So you have to be careful with this one, because the graft is just under the skin. So you have to be careful.
And the other thing is, if you have a good vein and you don't have good outflow to the foot, you can try to give them a shot with bypass. It may stay, but really outflow is very important to the foot. In my opinion, if you have a dialysis patient with poor outflow, I don't think anything gonna work. You're gonna exercise bypasses and things like that, and probably not gonna work. Endo work you can do for these patients, but doing bypass on dialysis patients with poor outflow, you have to think twice before you do it. I don't know what you think, Dr. Samer. So.
Yeah, I mean, one time we did a study, we look at that, we found that diabetic plus renal failure on dialysis plus heel ulcer, this is below amputation. No way you're going to heal it.
Heel ulcers in dialysis patients, I have never seen it heal, at all.
So when you get this three combination diabetes, failure on dialysis, and heel ulcer, give at least the patient, maybe try in the vascular, but don't be very aggressive, and try to prepare the patient for amputation early. What was the third question? Sorry, I think I lost the third question.
There were two questions. What is your duplex criteria for a good segment to put your bypass over it? Is there any duplex criteria like calcification, if you can compress the artery distally or not? Any criteria that you use and ask the duplex technicians to do it?
Ahmad, you want to answer?
I think I look angiographically. I look at the size, and then I personally don't rely a lot on duplex for these type of cases, because duplex is operator dependent. If you do it yourself and it's compressible, then that's good. But angiogram remains the main thing for these patients, because again, you look at the segment, you look at the outflow, and then also exploration. So when you do the surgery, you don't go to the above the knee SFA and then you expose there. You expose first in the distal part, and you see how the RE looks like. And if the RE looks terrible, you may think about not doing it. So I think that's what I do normally for these.
Okay. And how reliable is the compressibility of the artery by ultrasound?
It's reliable.
Reliable?
It's very reliable. That means there's not much calcification, and if it's angiographically looks good, this probably is going to be a good RE.
Yes, okay. I agree with that. I mean, duplex ultrasound angiogram, as I said, when you try to go distal, you need an angiogram. Duplex ultrasound only if you on angiogram you see no runoff at all, like desert foot, because sometimes you still have a flow, as you said. So before you go, like we used to do a blind exploration, but now if you have a duplex ultrasound and you see just trigger flow, you see the artery is open, you can try to explore it and see it, So, and then on the table, do an angiogram after you explore it. And then if it's a good artery, then you proceed with a bypass. And usually the artery we explore the most blindly is the posterior tibial, is the one we explore it if we don't have any artery below the knee. Calcification is not a contraindication. I will not affect your outcome. If you have artery is good but calcified, still you can do a good bypass and get patency. So calcification, if the artery will not affect the lumen, if the artery is still artery wide open and large, I don't think it will affect your patency. You can still do bypass, and you can still suture, but you have to be careful. And this special technique, how you do suture the calcified artery, but it's not contraindication. Doesn't mean that if you see calcified artery, you say I cannot do bypass. You can do bypass if the artery is wide open. And as far as I know, Muhammad can correct me, calcification without stenosis will not affect your patency.
Yes, it will not. And then our special needles also. There's Ethicon has a needle called CC needles. There's a black diamond needle which I don't like personally because it sticks to the. But there's a really nice needle called CC needle, and that would go through a wall if you want to, usually. But again, with calcification, it's all about the outflow, really. That's the main thing, It's all about the outflow. It's not, and whether you have a good vein or not, also.
Correct.
Yeah.
All right. More questions?
Last question. I'm really sorry about all of these questions.
Questions?
Would you go for a DSA post bypass, and would you cannulate the branch of the vein and go downwards? Or femoral? What is the approach you would like to do? And do you do routinely DSA after bypass?
I'll answer first. The way I train, I always do a combination angiogram. Even if I do fembop above the knee, it's just a habit. I learned it from my mentors. So I always do combination angiogram. I just do for the distal because proximal, always we worry about the distals, I usually leave one of the branch open. I do through the branch, I just do it. If above the knee, sometimes you may miss it without, but I like to do routinely. If you do below the knee, I think you have to do it. If you do distal bypass, I think you must do combination angiogram to be sure osmosis is fine, everything is okay. So I think it must below the knee. Above the knee may be optional, but for me, I just used to do it all the time. Muhammad?
Yeah, I do. Depends, to be honest. You're absolutely right. You should do below the knee angiogram. But in my practice, if I have a hybrid room that day, I do angiogram on every. If I don't have the hybrid room, I look with ultrasound. I see if they have. Sometimes they have palpable pulse. Sometimes they don't. But the right thing to do, like you said, below the knee, you should angiographically check if you can, and then above the knee, like you said, you do. It's good practice to do. If you have a place and you have the time and you have the ability to do it, you should do it. I think so. Although Doppler also can give you reliable information with this.
Yes, of course. If you have a Doppler, give you even better. I think Doppler is better than angiogram because it give you more hemodynamics. So angiogram could be misleading sometimes. So if you have a good, technicians, duplex ultrasound, intraoperative, it's much better than angiogram. But I don't have this one. There's why I do an angiogram. But no question.
One of the people I work with probably overkill. He used IVUS, he used eagle eye, small IVUS, but it's probably too expensive to do it, for that. So.
All right. Any more questions?
What is the CC needles? I'm not familiar with them.
CC needle is an Ethicon, very hard needle. It's for calcified vessels. It comes in 6 O's usually, and it's really. I'm sure I've seen Ethicon needles in the Middle East. It's a good needle. It's a very good needle. Basically, it goes through the calcium. It's designed for calcified vessels and makes your life a lot easier in these calcified vessels.
Mm-hmm.
And it's called CC. Yeah, it's Ethicon. I can send it.
Yeah, if you please. I'm really grateful. Thank you. Yeah.
All right. Yeah. You're still there?
Yes, Dr. Samer.
Next question.
23 years old man present at level 1 trauma after being stabbed in the left thigh. On admission, he is tachycardic and hypotensive, but is awake and alert. His complaint of pain and numbness of his left leg. He has a large pulsatile hematoma in the left thigh with absent popliteal and pedal Doppler signals. He was emergently taken to operating room and the left leg was explored and a transection of the common femoral artery identified and repaired. The vein was intact, although the femoral nerve appeared to be damaged. The expected neurological deficit would be.
Okay, they talk about the femoral nerve. Okay, so I don't know if you remember the anatomy. Femoral nerve. What most when you do fempop, what most people complain about? When you do a fempop, when you do a groin incision, always we push the nerve to the side, or we can damage some of the nerve fibers be damaged. So what people they usually complain of?
Numbness.
Yeah, medial aspect of the thigh, correct?
Yes.
very, very common, complaint after FEMPOP bypass or any groin incision already. But this is because we just cut some of fibers or push it. But if you cut the femoral nerve completely, then you have to see sensation, medial aspect in the thigh, but also it has a motor function. Do you remember which one, motor function? Let's go one by one. Maybe you excluded the easy, we excluded. Let's go one by one.
Decreased sensation of the medial thigh and calf.
Okay. Let's go next one.
Decreased sensation of the medial thigh and weakness of the knee flexion.
Let's see, knee flexion is a posterior compartment, correct?
Yes.
Next, knee flexion is sciatic nerve, so it's not one. So you see, sometimes you just exclude and you know what your answer. So this is wrong.
Wrong.
Next.
Decreased sensation to the entire lower leg with a weakness with knee and ankle flexion.
No, this is also sciatic nerve. This is a big nerve, so leg weakness, the whole leg, you cannot do the knee and ankle. So this is also posterior. This is not the nerve, correct? So this is wrong.
Decreased sensation to the anterior thigh and weakness of hip flexion and knee extension.
Yeah, and it makes sense.
This is the right answer, anterior compartment thigh muscle.
Okay, and E?
Weakness of the flexion and extension of the knee.
Okay, you see, flexion of the knee always a posterior compartment, so it's not. You see, so even if you don't know the answer, if you exclude the wrong one, you know what the answer is, We know it's a motor and sensory. So the first is correct, but it's only sensory. You want motor with it. So usually, if you don't know the answer, by excluding all of them, the right answer would be the D. Decreased sensation and weakness of the hip flexion and knee extension. This is a femoral nerve. Sciatic nerve is responsible to give you the posterior tibial and peroneal nerve, which is responsible for the foot and leg. Correct? And posterior compartment. So it's responsible for, knee flexion, and ankle flexion and extensions, all related to the sciatic nerve. Posterior nerve, we talk about it. We responsible for posterior compartment, which is dorsiflexion. Dorsiflexion of the ankle, whereas the anterior compartment peroneal nerve is responsible for dorsiflexion is the peroneal. Extension is posterior tibial nerve. So anyway, so that means, guys, you need to read for the exams these nerves, and you have to know what their supplies, because you may get many questions about it, okay? So you just need to go and read about them. Femoral nerve, tibial, sciatic nerve, posterior tibial nerve, and peroneal nerve.
Dr. Samer, have you seen a problem with sartorius flap along the lateral cutaneous nerve of thigh? Have you seen such complication?
Yes, I see it in redo, because sometimes, I don't see it when you do like a normal groin incisions. I see a lot of decreased sensation because we cut a lot of superficial nerves. But when you do like groin multiple redo, and I see some people, they cut the femoral. If you cut the femoral, I think I saw it once time, femoral nerve being cut, and he has a weakness, as you said. He cannot do dorsiflexion, knee extension, or hip flexion. But I think I saw it once in my life. I know, Muhammad, if you have experience.
I had one of the trainees put a stitch in it one time, closed, and patient had symptoms of femoral nerves. I took him back and I saw a stitch, so I took it out, and he got better over time with physical therapy. But that's the only, I've never seen it cut, so I don't know. The trick with dissection, just stick to the artery, don't go around. Laterally, there's the nerve lateral. Medial is the vein, you're going to get in trouble. So you stick to the artery, around the artery. So you were very close to the artery and dissect very carefully. That's the trick, for safe dissection, especially during redo. So
that's correct, yeah, because redo, sometimes the nerve, you can see the anterior and the nerves, The good thing is multiple branches, this nerve. It's not like one thick nerve. So even if you cut some, already you see like a motor dysfunction. You see a lot of sensory dysfunction from damaging this nerve. Rarely you see a motor unless you really cut it bad. And even motor is not very bad because other muscle can take over with the physical therapy. But mainly you see hip flexion is a problem, and the extension, yeah.
Yeah, and it's important, especially when you have lateral profunda exposure. Femoral nerve, you see it better, because that's where you get the profunda laterally. If you have redo groin and some things like that, you don't want to go into the groin. But you have to be very careful. Always stick to the vessel. Just don't wander around.
All right, 39. Oh, almost there. Hamad Dahman. Dahman, you want to take this one?
Yes, doctor. A 53-year-old man was injured in helmeted motorcycle accident where he sustained a direct impact to his abdomen. He had numerous rib fracture and penetrating chest wound, but no peritoneal signs. Upon evaluation, he was found to have cool, painful, and pulseless bilateral lower extremity. The CT shown in the figure. The best management for this patient will be.
Okay, so this is the CT. Okay, forget about this one. Hematoma here. You want to look. Okay, so what do you
He has a distal aortic just above the bifurcation injury, which is most likely thrombosed distally. Yeah.
Okay, but why thrombose here? What makes
Acceleration deceleration injury caused dissection, a traumatic dissection or transection of the artery, and yeah, but no full transection because no extravasation. So it's mainly dissection,
so you have
traumatic dissection.
arteries, okay?
Yes.
Dissection artery which cause complete almost occlusions, you know?
Yes.
You think is better? Can you do a thrombectomy in this patient?
No, because the intima is not intact most of the time.
Trouble if you try thrombectomy in these people, you don't even try thrombectomy because if you do thrombectomy,
Yes. You will make it worse.
yeah, because you have a like dissection. I mean, it's like dissection.
Yes.
Stage
Yes.
2, like going to do thoracic aorta, you know?
Yes.
Have a flap and dissection and cause complete occlusion. So you need to be fixed, you know? So to answer, let's go to the answers. Let's see what you want to try first. What do you think should be the best answer?
Yes. For this, most likely I'll explore a get control for both of them and do bypass most of the time, but I have to see.
I mean, it is nobody can say you cannot do that, but now, like with the thoracic transection, what do we do? So in the vascular first.
To do TVAR, and this one can, but yeah, but this artery is very small, so you can do, the only thing you can do is
the vascular now become is a main treatment, especially in the trauma patients, you know. And the second, he told you that there's no peritoneal sign. So he told you you don't have to open the belly unless you have. It's like, if you're opening the belly, it's okay. You can think about something surgical. But he telling you that, where is he? I read somewhere, no peritoneal sign. Does that mean I'm not going to open the belly unless if you want to do it? So do you think in this patient, endovascular or surgical repair is better? And less invasive?
I think, yeah, with no peritoneal signs and we don't want to open him, I think endovascular is still good option.
Just
very good option.
Yeah. You go there, cross it like a dissection slowly. I don't think it'd be difficult, you know, and then just put two cover stent, right?
Cover the kissing stent, yes.
Patient is already traumatized, you don't have to open the belly, you don't have patient stable or not. He's 53. That impacts the abdomen, he has numerous rib fractures, penetrating chest wound, so he's already, you know, sick guy. So the best, you know, fix his problems and get him off the table. So yes,
I didn't think about endovascular first because I have to fully heparinize him. He has full large hematoma up, so this might exacerbate even his abdominal problem, and he has rib fracture, everything. So penetrating chest injury, come on.
Okay.
So yeah.
Really, if you put iliac stents, I mean, you don't have to heparinize them. As I said, these people are already coagulopathics, and just iliac stent very quick. You go there, put two stents. I will not. And after surgery, you don't have to be aggressive, you know. Especially young people are clean. It's not like he has high resistance after the artery. You have to be aggressive. Of course, you prefer to put in antiplatelets, but it's not like you have to do it right away. So it's still, I mean, less invasive, I think. But if you are opening the belly anyway, like for some reason, Also, you have to think about putting a graft in patient, maybe already bowel injury. It's not a good idea to orthobiofilm and back in bowel injury, maybe has other injury, maybe contaminated wound, so there's problems. So, so I still think endovascular is the best option when you have a trauma, you know, either in the thoracic and the abdomen, anything you can endovascular, I think be the best option.
Yes, and the safest option.
Yeah, Hamad, what do you think?
I agree. I agree. You know, the endovascular options could be covered. You know, kiss and stents could be quick EVAR, depends on the size.
Yeah.
You know, you could. This is an endologic case. You can do. There's a graft called endologic. Fairly quickly, you can put it in. But open, it's pretty invasive. You know, for this patient. And regarding heparin, so we don't see a lot of abdominal traumas like that. I've seen maybe only a few in my career, but with thoracic traumas, we see a lot of them. We never heparinize if they have injuries. We infuse heparinized saline through the sheath, and we move very, very quickly. And that's what we do with these patients with head bleeds and with comorbidities. So, like Dr. Samer said, you know, these patients are they're already hypercoagulable, and you don't need to be aggressive with heparin. You know? So.
It's true. As it also TVAR, sometimes you can do without heparin or very low dose heparin. The patient has multiple trauma. Yeah, I agree. Here, because this is like stage, if you use same staging for aortic transection, this is stage maybe 2 or the patient. So you don't have to do an EVAR or any, you just do cover stent will be fine. Because but if you have a rupture, then you have to do a TVAR, you have to do an EVAR, sorry, or something else, or iliac and fem, whatever, you know. But if it's no extirpation, just occlusion, I think 2 cover stent will be more than enough, you know.
Yes.
Cover stent and faster, maybe also.
All right, let's see what's the option, Hamad. Yeah.
Bilateral covered stent placement.
Okay.
Aorto bifemoral bypass, axillary bifemoral bypass, operative thrombectomy, catheter-directed thrombolysis. So we exclude the aorto bifemoral, axillary bifemoral, operative thrombectomy, catheter-directed thrombolysis. I think if I don't have the facility, I will choose axillary bifemoral. But if I have the facility, I will go with the bilateral covered stent.
Well, I'll tell you, catheter thrombolysis is killing, and it's for sure not.
Yes. No.
It's dangerous. Axillary bifem, if he's an old guy, you know, but he's a young guy. Aorto bifem, I don't think it's a good idea because, again, abdominal trauma, you may have an infection there, you know. So if you don't have covered stent, I don't think, I'm just thinking, I may just go there and maybe that primary repair, maybe just open the artery, do primary repair, or I don't know, but I don't like it with aorto bifem. It's too much, I think.
Yeah. And if you were to do aorto bifem, you don't need to do aorto bifem here. You do aorto by iliac, you know.
By iliac, yes.
Have to go to the groin, but that's overkill. I mean, based on this study, covered stent is the fastest way to do it.
Correct, yeah. Right.
But
all right, there is somebody has a question. I think raised his hand. Who's that?
أنا محمد صلاح دكتور سامر. Have a couple of questions. للأسف يعني I'm sorry for the disturbance. What kind of covered stent you would choose, and an aortic single covered stent with fem is accepted or not? Lastly, if you are doing an aorto by iliac and it got thrombosed out of an iliac problem, would you go for jump graft from the aortic graft down to the femorals, or how would you approach this if you have this thrombosed aorto by iliac graft?
All right, start one by one. First question, what was the first one?
What kind of covered stent you would use?
So anyway, I mean, it's a lot of available in the market. Most of it will be balloon expandable, you know, covered stent. So we have VBX, you have Bentley, V12, and anyone will work. I don't think anyone better than one, but I usually most of it balloon expandable covered stent.
Right, and that's what I would do too.
Yeah, balloon expandable will be the best way. Yeah. Agree, Hamad?
Yes, absolutely.
Next question: if aorta by iliac thrombosed,
yes,
right?
What is the options that you would do? Jump graft to femorals, or jump graft one femoral and fem.
First, you ask aorta in iliac. You don't do aorta in iliac and fem. And why need to do aorta in iliac and fem? I mean, if for the stent, you always with two stents is easier. If you have aorta by iliac and one limb thrombose, you have to know if this is an early thrombosis or late thrombosis. Make a difference. It's something like happy on the table or like next day. If it's happy on the table, that means he has technical issue. Do you have a technical problems? I don't know. You have to see what's the problems, you know?
Yeah, exactly.
I would do thrombectomy and do an angiogram and figure out what's the problem. Either kink, stenosis, the problem is a stenosis, you know, something happens technical, no question. So if you just do a jumper graft, you didn't fix it. So what I will do, I'll do thrombectomy and do an angiogram and try to figure out what's the issue and then try to fix it. I think
thrombectomy through femorals or through the graft itself.
You already open, right? Imagine you already open. You did aorta by iliac. And no, you can open the graft. Was a bit you have so you went aorta by iliac and thrombose on the table.
Yeah.
It's hard thrombectomy from the external iliac, and yeah, most probably I will go from the groin and through thrombectomy and try to fix it. Maybe in the vascular, maybe some kink. I put a stent there and fix it. You know, I don't have to do a bypass. I don't think I need bypass right away, unless if it came with a late occlusion is different, but something immediately occlusion, technical, and mostly I will do a thrombectomy, angiogram, and try to fix it in the vascular.
I've seen a Eurobifem, one Eurobifem occluded. I helped somebody with something many years ago, and then the flushing was not done appropriately, and the patient, so you have to flush these, like Dr. Samer said, you have to figure out the etiology. And mainly, you know, they had debris. Some of these, especially for occlusive disease, they have large debris. But you don't just jump and do major procedure without knowing why, you know. So,
as I'm saying, the most important when you have something failed to know why it failed. You know, this is the first thing you have to know. Even when something come later on, always you have to figure out why this failed. Like you do fem bypass, and after like 2 days, 3 days, failed. Why it's failed? This is an inflow problem. It's an outflow problem. It's hypercoagulable patients. You have to go review to your CT angiogram. You review everything, you know, and then maybe your choice of surgery was wrong because outflow is bad. Then maybe you have to do a jump graft. Maybe your inflow was bad, so you have to go and do endovascular repair. If you don't have anything, then you do a thrombectomy, do an angiogram, figure it out. But the whole thing is that you have to figure out why it's happening. You know, you don't blame everything to hypercoagulability. First, blame yourself. The last thing you have to blame the patient for hypercoagulability. But 90% is something wrong. Something happened wrong. So I don't know what, but you have to figure it out. If you don't figure it out, this will happen to the next surgery. I mean, if you do jump bypass, it's going to happen for the jump bypass. You see, why is not happen? See, if you don't figure out what's the problem and fix it, if you keep doing the same mistake, you're not going anywhere.
Okay. So as a first step, you would go for thrombectomy,
yes.
Plus minus iliac stenting if needed. If all of this failed, you would. What would be the next step?
No, I do a thrombectomy with an angiogram and see what's the problem. Is it a kink? It's maybe outflow artery was bad, was my bad choice. Maybe the anastomosis is bad. Maybe he has a thrombus above the way I did my bypass graft. Maybe I have to revise it. You have to figure it out what's the problem, and then you decide. It's not like 1, 2, 3, 4. But the whole idea, you want to remove the clot and do an angiogram to see what's the problem. Because as far as the clot there, you cannot tell what's the problem. You see? I just do out. It's not. Maybe it has like suprarenal stenosis. You don't know about it. It's causing all the thrombosis.
Oh, yeah.
Then you do a jump bypass and this thrombose again. Maybe you have suprarenal lesion just embolizing. I don't know. Maybe crush injury from the clamp. You put it there. You know, you have to figure it out. So angiogram, I think, is must. You know, you have to do an angiogram.
Okay, that's perfect. Thank you a lot. Thank you a lot, Dr. Samer.
All right, let's go to the last question. I don't want to give you late here, guys. Was number 40? Yeah, 40. Let's go to the last one. Who is there? Saeed, you want to take it?
Yes, sure. 32 years old man and recreational triathlete has pain with exertion in both calves and feet, which has worsened over the past several months. A wound has been present on the dorsal aspect of his right second toe for 3 weeks. His primary physician had obtained an MRA figure, the diagnostic imaging approach that would best help with planning for surgical treatment of the left leg. Left leg would be. So he has actually,
So he's an athletics, right?
yeah,
He's an athletic. Anytime they do athletics with pain, with exertion,
complete entrapment.
okay, you think about popliteal entrapment syndrome, correct? And you can hear his popliteal artery is occluded, correct?
Yeah.
And distal embolies, look at that. He has multiple embolies there here, because the reason why he has, he has an ulcer. Okay.
Yeah.
So tell you what diagnostic imaging approach that would best help you planning your surgical treatment. So treatment is surgery, right? Entrapment syndrome, we do a surgery, correct? It's no endovascular treatment for it.
Yes.
Correct. So what is the test you need diagnostic imaging best to help you planning your surgery? Let's see one by one. Okay.
So duplex of left popliteal artery in neutral position.
Will not give you any information, correct? So this is wrong.
Correct. Duplex of left popliteal artery in flexion extension.
This is the confirms the
Yes.
diagnosis, right?
Yes.
He has a popliteal entrapment syndrome, right? But
Yes.
doesn't matter in your surgical, what he said.
Planning.
He wants
The planning.
surgery, no. But it's not any information. You already know that he has entrapment syndrome from the MRA, right?
Yes, correct.
So,
Axial cross.
Yeah.
Axial cross-sectional imaging from the MRA.
What does cross-section help you? To find the deformity, right?
Okay.
What entrapment syndrome? What happens in entrapment syndrome?
So the artery is entrapped between, it depends on the type 1, 2, or 3. So is it trapped between the heads or not? Depends.
What's the muscle? Remember?
Yes, I think type 1 is the medial muscle and the 2 is
Gastrocnemius muscle, right?
yes, gastrocnemius, yeah, sure.
Where it's insertion. So what that means is that you want to know what type so you can cut it, right? Because it's a whole surgery. Cut it. Okay. So you want to know which is head, which where is the displacement of the insertion of the medial head of the gastrocnemius muscle so you can cut it. So where do you get this information from? Where? From the MRA, right? From the axial cross-sectional imaging.
Okay.
Is only you can see the muscle and you see the where is the malposition of the head of the gastrocnemius muscle.
Okay, so then C. So the angiography of the left popliteal artery in the neutral position, that's no. And the angiography of the left popliteal artery in flexion and extension, no, that's I think in the diagnosis only. So C.
Even if you don't know the answer, if you exclude the others, then you go with the C. But usually this is what you want. See, when you do entrapment syndrome, you want to know what type is it, where is that muscle insertion so you can cut it. This is very important. So to look at the axial cross-sectional imaging is very important, MRA. Muhammad, you want to add something on this one?
No, not really. This is a great demonstration. Yeah. Also, you guys look at that MRA, how beautiful it is here.
Yeah.
So for below knee MRA, usually it's pretty good, and you don't need an angiogram for this, other than just looking at what Dr. Samer said, look at the muscle insertions. So it looks pretty good.
Yeah, it's very nice, really. All right, guys, I think it's enough for today. We already finished till 40, so it's good. 41 we'll start next week. Any question before we leave? All right, thank you very much.
Thank you, Samer.
Thank you. See you guys. Thank you.
Thank you.
Guys, take care. Bye-bye.